Hi, I'm Jared Gardner. I'm here today with my dermatopathology fellow, Dr. Ed Fulton, and we're going to talk today about one of my favorite entities in soft tissue pathology, perineurioma. It's a benign and beautiful tumor, and that's why it's great. It's really pretty microscopically, it's got some cool features, and it's also totally benign, which is great news for the patient. So it's a tumor we can be happy to diagnose for multiple reasons. They're relatively uncommon, but there are a handful of other things that can kind of look a little bit like this, and so it's a good tumor to know about and keep in your differential diagnosis when you're dealing with what looks like a bland, spindled, fibroblastic tumor, okay? Perineuriomas are benign tumors made of perineurial cells, all right? And they have a tendency to make nodules that are usually a few centimeters, somewhere between 1 and 10 centimeters, most of them are around 3 centimeters. And they often arise in the subcutis, although they can occasionally be in the dermis, totally in the dermis, or in the deep soft tissue, okay? But most of the ones I've seen are in the subcutis and are just a few centimeters in size. Microscopically, the key feature that you want to see in perineurioma is spindled cells that are swirling and whorling and making these kind of whorls, okay? And let's look at this example. And here's a beautiful, perfect example of a whorl. So whorling and swirling is another way to say that is basically this is a kind of variation of the storiform pattern. Storiform pattern that can be seen in dermatofibrosarcoma protuberans, DFSP, and other tumors. It tends to have swirling and whorling, but the swirling in perineurioma usually is much more dramatic. It makes really oftentimes these concentric circles that are kind of lamellar. The spindle cells with intervening collagen wrap in circles and often are centered on little blood vessels like we see here. There's a vessel in the middle, and we have these kind of spindle to oval cells that are swirling around the outside in layer after layer after layer. And the layers kind of stack on each other and give this very kind of lamellar, kind of concentric rings of collagen and little space crack artifact and spindle cell layer after layer, often around with vessels in the center. You can see more over here. Each little vessel is kind of got a little swirl around it, and some of them have really big swirls around them, like the one I showed originally, and here's more. So this is what perineurioma looks like when you're lucky, when they're really classic. Sometimes they don't have such dramatically beautiful swirling, so it helps to keep this in mind. If you even get a vague sense of swirling and it looks like you've got a collagenous, spindled to oval cells, and it's bland, okay? Perineurioma usually does not have much nuclear atypia, and mitotic activity in most cases is either absent or very rare. You may find like a rare mitosis. Chris Fletcher and Jason Hornick, I believe, were the authors on a real nice paper about perineurioma, and they found that a small subset of cases could have higher mitotic activity and can have scattered random pleomorphism and still behaved well in their series. And there is such a thing, supposedly, at least, as malignant perineurioma, although I don't really like that term. I think of those tumors probably as more likely being malignant peripheral nerve sheath tumors that just have a lot of perineurial differentiation. And if you haven't watched my video on MPNST, I'll put a link in the upper corner up there so you can check that out in your spare time. So anyway, if it looks really ugly or has lots of mites, you should really be hesitant to think about diagnosing perineurioma. Usually they're very bland. Let's look at the spindle cells in closer detail. And here's a good area. And again, we can see a vessel here, and the vessel's kind of at an angle. See, here's the other end of the vessel. Here's like a lumen right here and a lumen here. So we're kind of cutting along a vessel that's kind of looped. So we're looking at kind of a tangential section. And again, you can see the cells swirling around it. And you might notice something. The cells in here, close to the middle, they look like they're kind of oval nuclei. Whereas when you get towards the outside of the swirl, the cells look more spindled. And the reason for that is probably due to, at least my understanding and what I've been taught, is that the cells of perineurioma are not just spindled cells with long needle-shaped nuclei. They're actually kind of an oval disc, a flat disc. So if you cut them in one direction, in one plane of section, you'll see an oval nucleus. But if you take that nucleus and flip it 90 degrees and then cut it, it will look like this, a spindled nucleus. And think back to what perineurial cells do. Perineurial cells are kind of the peripheral nervous system counterpart to meningothelial cells. Just as meningothelial cells in the central nervous system wrap around the central nervous system nerve structures and make a meninges, a lining around the brain and spinal cord. In the peripheral nerves, you have perineurial cells that wrap and swirl around the outside of every nerve bundle to kind of protect the nerve and probably perform a lot of other functions that I don't actually know. So what these cells are is they're kind of these flattened oval discs, okay, kind of like a plate. And if you look at a plate from above and you have it sitting on your countertop, it looks round, right? And if you flip that up and stand it on edge, it will look spindled, right? Or it'll look thin. And that's what you're seeing here. So you can have oval to spindled nuclei depending on the plane of section. And the other thing that the perineurial cells have is they have long, thin cytoplasmic processes, kind of bipolar cytoplasmic processes. At each end of the nucleus, you have a thin little streamer or wisp of cytoplasm that extends out. See, right here's a nucleus of a perineurial cell, and you've got a wisp of cytoplasm and another wisp of cytoplasm. So these bipolar, thin cytoplasmic processes, they can sometimes be hard to appreciate on the H&E, but when you see the immunostains, which we'll talk about towards the end of this video, these tumors classically stain for EMA, Claudin-1, and or GLUT1, ideally all three together, but in real life it's a little bit more complicated. We'll discuss that in a minute. But when you do those stains, they tend to highlight these little streamers of cytoplasm, these bipolar, long, thin processes better. And the role of those thin cytoplasmic processes in normal perineurium is to wrap around the structure of the nerve, right? Again, it's a similar kind of function to what we see in meningothelial cells in the central nervous system. Okay, so swirling and whorling growth around vessels, oval or spindled nuclei, and thin, tapered, streamer-like processes of cytoplasm extending on both sides. And let me go back to low power. Low power, usually perineuriomas are relatively well circumscribed. I have occasionally seen more infiltrative examples into the fat, which I'll show in a minute. You gotta be really careful there to not confuse it with DFSP. And then, like I said, Hornick and Fletcher have reported some cases with more atypical features like a muscle invasion, which I think they only had maybe one case in their series. And I'll put a link down in the video description to their paper and also some other scientific references that I may mention during this talk that I find useful in better understanding this entity. Let's go away from the tumor and go to some other skin here. Okay, this is a shaved biopsy of a sebaceous carcinoma, but the reason I'm showing it is not for that, but just in case you're curious. Look at all those bubbly nuclei in there. Those are sebaceous, malignant sebaceous cells. Okay, but the reason I want to show it is because down here, somewhere, there we go. There is a nerve. Here is a nerve bundle. It's got its Schwann cells inside, and it's a little bit cut at a funny angle and has a little bit of a notch in it, but you can still tell it's a nerve, and around the outside, this layer here, surrounding and wrapping the nerve, is the perineurium. And these little spindle cells here are perineurial cells, and also sometimes perineurial fibroblasts can be trapped up in there. Here's another little piece of that same nerve, probably cut at an angle, and again, it's got a little perineurium around the outside. I think there's one other nerve right here. In the more superficial dermis, the nerves are much smaller. You can see there's an axon right there. I don't know if it'll show up on the screen. Yeah, here, if we flip the condenser, you can see there's a little axon in the middle, a little space where the myelin would be. It's washed out during processing. The nuclei here are the Schwann cells. And around the outside, this thin little wrapping of perineurium. Okay, so that's what normal perineurium looks like and what perineurial cells do in the normal nerves. All right. Now, this is an EMA stain, epithelial membrane antigen, also known as MUC1, MUC1. I didn't know that actually for a long time, so now you're probably ahead of me if you're a resident and you know that. Good for you. So these are those two sections of nerve we looked at on the H&E, and you can see the nerve itself is negative, and you can see this swirling, multi-layered band of EMA staining in those wispy little spindle cells. That's the perineurium. So perineurium is a nice normal internal control when you're doing an EMA stain, actually. So are sebaceous glands, and so are the lumens of the eccrine coils, if you're in the skin. And here's that other nerve we looked at. You can see it's right next to a little blood vessel. And then here's the nerve, and here's the perineurium staining with EMA. So that's normal perineurium and what EMA stain looks like around perineurium. So let's look at some other examples to get a better feel for the range of features that we can see in soft tissue perineurioma. And I forgot to mention there are kind of 4 variants of perineurioma. There's soft tissue perineurioma, which is what I showed the first case and also this case. There is sclerosing perineurioma, which often occurs in the dermis on acral skin. I'll show you a couple of those. And I feel like those two are relatively similar to one another. And so those are the 2 entities I'm going to discuss in this video. There are 2 other forms. There's a so-called intraneural perineurioma, which I almost feel like might actually be a separate type of entity. It looks quite different from the other perineuriomas, and some people have even suggested it's a form of intraneural perineurial hyperplasia, but we'll have to save that for another day. And then the other form is a reticular perineurioma, which has this very lacy kind of network of spindled cells with lots of little holes, reticular kind of spaces, spaces in between this reticular meshwork of cells. You can go and look up some papers on that and see it looks totally different, and it's kind of shocking, honestly, that it ends up having perineurial expression because it doesn't look like it should be a perineurioma. So anyway, I don't have an example of that in my teaching set, so I want to make you aware of those things, but we're just going to focus on soft tissue perineurioma and sclerosing perineurioma today. So here again is a nodule, a few centimeters in size, relatively lobulated and well circumscribed. This one looks a little different from the other because it has spindle cells with intervening collagen, but in addition, there's also some bluish mucin or myxoid change to the background. If you're a dermatology trained person, bluish hyaluronic acid and glycosaminoglycans are usually called mucin in the derm world, but in the path world we tend to call them myxoid. But it's ground substance or hyaluronic acid, and you can see that there's a variable amount of it in the background here. So a relatively decent number of perineuriomas will have some mucin or myxoid change in the background, and that's important to recognize because there are other tumors in the differential that can also have some myxoid background change. This one has some swirling areas, but it's a little bit more vague than the previous case. That first case I showed was just so amazing and classic. Here, though, you can get the vague impression of swirling spindle to ovoid cells and intervening collagen. And if you're having trouble seeing the pattern, sometimes it can help if you get here on higher power, like I'm on 20x now, and then flip the condenser, and it really makes the collagen stand out and become more refractile. And those little collagen fibers can kind of help highlight the actual swirly pattern that you're seeing. But like I said, this case is not quite as dramatic, but still ended up staining with perineurial markers. And here, these little areas here are kind of some little small mini whorls or swirls of perineurial cells. And they are not actually centered on the vessels in this case. The vessels here don't seem to have much whorling or swirling around them, okay? So anyway, that is another example of a perineurioma with that swirling growth. And again, going in closer here, you can appreciate really nicely what I mentioned in the first video. These cells are perineurioma cells, and look at them. They're round or oval shaped. They're flat discs. Here, these elongated cells here are the same exact cells. They're just turned 90 degrees. They're turned on their side, and so when we section through them, they look like little spindled nuclei, but that cell and these cells are the same cells. It's just a matter of what angle you're sectioning them at, whether they look spindled or ovaled around, because they're like little plate-shaped discs. Okay, so that's another perineurioma with a little bit of myxoid change and not quite as dramatic of a whorling or swirling growth pattern. Here's another example that, let's see if I can get the lighting right. It's a little bit washed out. It's a small nodule, it's circumscribed. This one looks a lot more collagenous and kind of fibroblastic-like than the other case. You could also think even of a neurofibroma here. There's kind of spindle cells, fine collagen, a touch of a kind of a myxoid background here. When you flip the condenser, you can see the delicate little fine shreds of collagen in between with a loose myxoidy looking background and bland spindle cells. This one is a lot more spindled looking than the other cases I showed, doesn't have as much of that oval look. So here, what else could we think of in the differential before we think of perineurioma? Because the swirling, again, is not really dramatic here until you start looking around. You can find a couple examples where you have a swirling or whorling look to the tumor. Here's some more. But you could definitely think of neurofibroma in a case like this. And perineuriomas will be S100 negative because they're just made of perineurial cells, whereas neurofibromas will be S100 positive. And again, we'll talk about immunostains at the end of this video. And if you haven't seen my video about neurofibromas and neurofibromatosis, you can check that out. I'll add a link in the upper right-hand corner and in the video description down below. The other thing you might think of is low-grade fibromyxoid sarcoma, because it can definitely have a variety of a mixture of myxoid change and delicate collagen, and it's made of bland, benign-appearing spindle cells. I'll discuss that in more detail as we get towards the end of the video in the immunostain section. And at some point I will make a separate video all about low-grade fibromyxoid sarcoma, and I'll post the link to that once I get that finished at some point. All right. So this is another perineurioma, and again, the collagen in the background is more pronounced. And oh, there. But see, when you look around, you can start to find nice whorling, swirling architecture here. Okay? Really nice example once we find the right spot. So if you get even that vague sense, think about it. If you're thinking about a nerve sheath tumor and then S100 is negative, you should automatically think about perineurioma in your differential diagnosis. At least that's the way I think of it. If I think it's a neurofibroma and then S100 is negative, I wonder, oh, could it be a perineurioma? Could it be a DFSP? Could it be a low-grade fibromyxoid sarcoma? I think of those three entities together. Now here's a slightly unusual example. This one's from acral skin, but the reason I wanted to show this is because here the whorling growth is not centered on vessels, but rather on dermal reticular collagen bundles. And you can see though, it's a dramatic swirling and whorling of growth of the perineurial cells around individual tiny collagen bundles here. So really kind of a cute little pattern that I really like. It's very pretty. And I'd say this is not a common pattern, but it's definitely a distinct and interesting pattern. So again, when you see whorling or swirling of spindle cells around anything in the dermis or the subcutis or wherever your tumor is, always keep this in mind. And I apologize, this slide's been beat up a little bit. It's got some nicks in the glass and there's some scratches in the tissue itself. But again, like the previous cases, a couple centimeters in size. It's got a very circumscribed appearance. You can tell that we have a mixture of pink collagen and blue myxoid backgrounds. And there's a lot of cracking artifact here. Cracking between the collagen, bland spindle cells. And there are some whorls, like here, you can start to pick, once you get used to the whorls of perineurioma, you can start to imagine them better. It's kind of like story-form pattern in general. It's hard to describe it, but once you've seen it a handful of times, you can really start to recognize it. The reason that I'm showing this case is this case has quite a bit more collagen and a lot of a kind of cracking artifact, but this is the kind of lamellar growth. The spindled perineurial cells and collagen kind of stack in lines like this, okay? So they're kind of either, when they're swirled or whorled, they make lamellar kind of concentric layers. And here, these are kind of stacks of the perineurial cells and intervening collagen, and they're all lined up in this kind of lamellar fashion, kind of like a baklava or something, like the layers of phyllo pastry. So now I'm hungry for a baklava. But you can see this kind of fine, delicate layering or lamellation of the spindle cells and the intervening collagen. And again, that's a good example of that kind of pattern here in a perineurioma. And this one, like I said, has myxoid change as they do on a relatively regular basis. Here's some more of that myxoid change. And you can see some areas are more myxoid and other areas are more collagenous. And that's part of the reason it's really important to keep low-grade fibromyxoid sarcoma in mind as an alternative in your differential when you're considering perineurioma, because low-grade fibromyxoid sarcoma has a variability between collagen and myxoid change in the background. And again, I'll address that in another video at some point. Okay, so and again, from low power, you can really see the lamellar pattern too. It really, this case has a really dramatic lamellated growth pattern with a lot of kind of a crack artifact there. You could potentially confuse it with a sclerotic fibroma or so-called plywood fibroma, but in that I think the crack artifact is much more swirled. You don't tend to have as much myxoid background. It's usually a little less cellular, and also those are usually small nodules in the dermis, and I rarely ever see them as a few centimeters or in the subcutis. So usually small dermal nodules for the sclerotic fibroma that can sometimes be seen in Cowden syndrome. Here's another example that is very similar to the last one, actually, not quite as myxoid, but again has a lot of collagen in it and has a very kind of stacked lamellar layering of the collagen and the perineurioma spindle cells. Again, a real nice example of that. So I think that's a pattern to keep in mind too, even if you don't see the nice whorls or swirls. If you start to see these real distinct, unique looking stacks, and again, remember these cells, their job in the body is to organize and to layer together and wrap around the nerve. And so it makes sense that when they form tumors, they have this tendency to want to layer and line up next to each other. You know, tumors, oftentimes the cells will in some ways recapitulate what the cell would normally do if it were a normal cell. So this is another nice example, very, very beautiful pattern again. And here's another small nodule that's circumscribed. A lot of collagen in this one. And the reason I wanted to show this one is that you can really see the collagen pattern here can kind of help you pick up on the swirling growth pattern and the whorls. And then, again, a closer look at the cells, they're bland and spindled or oval depending on the cut, and they really do look very similar to fibroblasts. So I think telling apart fibroblastic or myofibroblastic tumors or proliferations from neural or perineurial proliferations purely on H&E can be quite challenging, actually. Sometimes I think something will be neural and it ends up being fibroblastic, or vice versa, or perineurial. And so sometimes immunostains are needed if we're struggling to tell these things apart. And this is an entity that I usually will perform immunostains to help confirm the perineurial differentiation. So I might suspect it on H&E, but I almost always do immunostains to help confirm it. Now, let's show sclerosing perineurioma. So these have a lot of similar features, but like I said, they're usually on acral skin, often on the hands or the fingers, and they have a dense abundance of collagen in the background. And the collagen, because of the dense collagen, it makes the cells look a little different. They tend to look more round and almost epithelioid. They can have some cytoplasm around them. Let me find the area. And they get those kind of round or epithelioid cells get compressed in between the dense collagen, and they do this. They make cords or chains. They line up in single file rows and then get compressed in between the collagen. So the more rounded cells that are making cords and chains in a sclerotic background, when you see that in a nodule, particularly on the acral surfaces like the finger or hand especially, think about sclerosing perineurioma. And oftentimes you'll still see background areas that look more like a kind of a regular perineurioma, like over here. This is more spindled and kind of that lamellar stacking with a little bit of crack artifact in between, kind of like some of the other cases I showed. And I think there's a little nodule over here that looks a little bit more similar to the previous cases I showed, where you have kind of oval to round cells, and depending on the cut, you can see the nuclei as either oval or as spindled. So, and here there kind of are little vessels here that are in the middle of this one. This is like kind of a giant whorl or swirl around a central little vessel. So sclerosing perineurioma, acral surfaces, abundant collagen, and keep a lookout for that little cords or chains. Now remember, a lot of other soft tissue tumors can have rounded cells that make cords or chains. Most of them look different from this tumor. I think the one main consideration I would keep in mind is myoepithelioma of soft tissue. They can be spindly and they can have cords and chains like this. And I've definitely seen some where a perineurioma looked like myoepithelioma and vice versa. And EMA will often stain myoepitheliomas of soft tissue as well. So the staining can overlap a little bit. Myoepitheliomas usually do express S100 though, most of them. And so that would of course be negative in a perineurioma. And here's another example kind of almost a heart-shaped piece of tissue here. It's definitely from acral skin. Look at that thick corneal layer. If you haven't seen my video on normal skin histology, I'll put a link in the upper right-hand corner if you need a refresher on what acral skin looks like. You can check out my skin histology video. Again, from low power, dense collagen. Look at the adjacent dermis over here. It's this color pink. And there. And then here in the tumor, much more dense collagen, much more pink looking. And you can see from low power even that the cellularity is variable. We have a more cellular zone up here. Down here is much less cellular and much more sclerotic. Here's that dense sclerotic collagen, and the spindled and round perineurial cells are kind of trapped in between that. And up here, just like in that previous case, it looks so similar. You've got a little vessel in here, and you've got a whorl and another whorl over here whirling around vessel. So again, finding those whorls can be really helpful. But if you just had an area like this, you might really struggle to think, gosh, what is this? It's dense collagen, some kind of nondescript spindled or oval cells. You might think of like a fibroma of tendon sheath because there's crack artifact, which are also seen in fibroma tendon sheath. You might think about a fibroma of some sort, and I'll talk about this in another video too at some point, but don't ever call stuff benign fibroma not otherwise specified in soft tissue. That's how you miss things like low-grade fibromyxoid sarcoma. Anyway, there are several subtypes of fibroma that are well described, but don't just say, well, it looks like it's a benign fibroblastic thing and I don't know what else to call it. So benign fibroma, that's dangerous, okay? Because there are things that look like a benign fibroblastic lesion that are malignant. Low-grade fibromyxoid sarcoma being the main example of that. Okay, and I think that's the main feature here on this case. All right, one last example and then some immunostains. Now this is a perineurioma that has something different than I've shown you before. It has pretty dramatic infiltration of adipose tissue, okay? I have seen this a few times in perineurioma, and again, I probably would not have shown this case except that I have beautiful, perfect immunostains on this one example, so I thought it's a good example to show because the immunostains worked really well. The main thing you should think of when you see a bland fibroblastic looking or bland spindled tumor with collagen in the background and entrapment, diffuse, extensive entrapment of adipose tissue, the main thing you should think about is dermatofibrosarcoma protuberans, DFSP, okay? And like I said earlier, DFSP and perineurioma, they both can look alike because they both have whorling or swirling growth pattern. We tend to use the word storiform to describe that pattern in DFSP, but it certainly can overlap quite a bit with the whorling pattern that you see in perineurioma, okay? And the nuclei of the cells can look relatively similar. They're both bland lesions, despite the name, despite dermatofibrosarcoma being a sarcoma, it is a translocation sarcoma, so it does not have pleomorphism, almost never. So it looks bland. Cytologically, it would look benign, and it's only by its growth pattern and its behavior that we recognize it's a malignancy. Okay, so this is not a DFSP, but we had to do some workup to rule that out, of course, okay? But you should always think about DFSP when you see this honeycomb pattern of fat entrapment in a bland collagenous spindle cell lesion, all right? So anyway, just know that's kind of a caveat that fat entrapment is not the normal finding in perineurioma, and basically you have to think that that's DFSP until you prove otherwise, either with immunostains and or molecular testing, okay? So here are the stains. This is EMA, epithelial membrane antigen, which is diffusely staining this perineurioma. Now you may say, well, that's not very exciting or dramatic. It's kind of weak. It's not really strong. But trust me, in my experience, this is actually a really good example of EMA staining a perineurioma. I have not had good luck getting EMA to work very well for perineuriomas or other spindled soft tissue tumors, and not just in my lab currently, but in multiple labs that I've seen EMA performed. It often tends to be very weak, very focal, very patchy. It works fine for epithelial tumors and some other things, but when you get into spindly, little bland spindly tumors where you're thinking of perineurioma versus other fibroblastic tumors, I find that EMA often is kind of disappointing in that context. It tends to be very weak and focal and patchy, and I don't know if there's some trick with antigen retrieval or what that needs to be done, but I've definitely seen that from multiple different labs that there's a difficulty with that. So sometimes if I think it's a perineurioma and I just get even a little focal EMA staining, I'll be happy with it. Here we've got really nice staining, and we also can see right there's a nice example of a whorl around a vessel, a nice whorl around this vessel here. And the EMA is staining nicely, okay? So EMA is a great stain for this, but EMA is not specific for perineurium or for perineurioma, okay? The two other big differentials that I mentioned, DFSP and low-grade fibromyxoid sarcoma, also known as Evans tumor, both of those can stain with EMA relatively often, actually. So that's a real problem, right? So if EMA is positive, that's great and helps support the diagnosis of perineurioma, but it doesn't totally exclude either of those other entities, okay? So there are a couple other markers we can use to help us in that regard, okay? One of them is this marker. This is Claudin-1. Claudin is a cytoplasmic membrane junction protein, if I recall correctly, and it's really nicely expressed on the epithelium of the squamous epithelium, or in the skin, or squamous mucosa. So let me see actually if I have an example control here. No, I don't. But it will actually really have a nice membranous pattern if you look at the epidermis with it. So if you need a control, that's a good control to use. Okay, Claudin tends to stain most perineuriomas, and that some of that work was published by my mentor and her, Sharon Weiss and her colleagues. And so Dr. Weiss really liked using Claudin for this, for perineurioma, because it tends to stain, and in my experience, it tends to work a good bit better than EMA a lot of times. Okay, and one thing that's helpful here that we can see on the Claudin particularly is this. Those long, thin cytoplasmic processes I talked about at the beginning of the video, you can really see them highlighted beautifully on the immunostain. Look at these thin little straight streamers of cytoplasm extending way out to the sides of the nucleus. So all of these little thin, wispy lines of staining that you're seeing, these are all the cytoplasmic processes of the perineurial cells. I think there's another area that's even better in here. Here we go. So you can really appreciate how long and thin these spindled cells are. And again, they're forming a whorl around this blood vessel here, okay? So that's a nice example of Claudin-1, and it tends to have this, you can kind of see that it's a nice staining of the processes, but it's also kind of granular. It tends to be this kind of punctate, granular, dot-like staining along the nuclear membranes, and the cytoplasmic membranes. And the cytoplasmic membranes of these long, thin processes here are so close together that it just looks like a solid line when it's staining, okay? So that's a nice example of Claudin-1. Claudin-1 is really good for perineurioma, but again, not totally specific. At first, there was some thought that it might be, but it has been described in low-grade fibromyxoid sarcoma, particularly the examples of low-grade fibromyxoid sarcoma that have a whorled growth pattern and have a perineurioma-like appearance. So the very time where you need a marker to help you, Claudin, at least in one study that was published, and again, I'll put the link down below, actually stained the majority of the low-grade fibromyxoid sarcomas that had a whorled pattern. So that's a dangerous thing there. And it's not usually positive in DFSP, but I've at least seen one case report of a molecularly confirmed DFSP that did have some Claudin expression. So again, it's not a perfect marker, but it can potentially be helpful. And then here is the last thing. This is GLUT1, and GLUT is a membrane protein that allows glucose transport. Okay, it's seen in red blood cell membranes, and also can be seen in a variety of soft tissue tumors, but is particularly a good marker, I think, in the setting of perineurioma. Look at that beautiful whorl there. Isn't that amazing? Just incredible. This is why I love these tumors, just so pretty. And again, you can really get a nice appreciation for the thin, streaming cytoplasmic processes here. And so this case expressed EMA, Claudin-1, and GLUT1 all together. All of that together as a panel, I think, is very helpful for perineurioma. GLUT is usually negative, both in low-grade fibromyxoid sarcoma and DFSP. I have seen a rare, I think, single report of GLUT staining in a molecularly confirmed low-grade fibromyxoid sarcoma, but to my knowledge, I don't believe it's been reported yet in DFSP. Surely at some point it will. You know, no immunostain's perfect. There's always exceptions, but I think when you add all those things together, it can be helpful. The last thing I'm going to show is CD34. Now, CD34 stains about 60% of perineuriomas. And again, when our differential includes DFSP, DFSP is almost always CD34 strong diffuse positive, with the exception of the fibrosarcomatous variant. here in this example, we got lucky. There's a little bit of patchy staining for CD34, but many, if not most, of the tumor cells are negative. So if you do a CD34 and it's negative or only kind of patchy positive, that's a strong argument against dermatofibrosarcoma protuberans, okay? Particularly if you have all of the other markers positive. But if your CD34 is positive, then it doesn't really help you, right? Because it could be perineurioma or it could be DFSP. So if you have something, especially if you've got fat infiltration, it looks bland and spindled and whorling, and you've got EMA and CD34 expression, that's the time to send the case for FISH or RT-PCR to look for the collagen 1A1, PDGF-beta translocation 1722, that is present in the vast majority, almost all examples of DFSP. So thankfully, if you have access to molecular testing, that's an easy way to sort this out. And again, perineuriomas are benign. They rarely recur locally, so they don't really need to even be re-excised, whereas DFSP is locally aggressive and needs a large surgery. So distinguishing between these two is really important for patient care. And if you have any doubt, that's when I send the case for molecular. When I have an obvious DFSP, I usually just diagnose it, sometimes even on H&E or just with a CD34. But if I have doubts and I think, oh, could it be perineurioma or DFSP? Or I think it's probably not DFSP, but I'm not totally sure. Those are the times where I'll use molecular testing, and if it's negative, I find that very reassuring. Okay. The other thing I would mention is that for low-grade fibromyxoid sarcoma, there's a stain MUC4, MUC4, that is positive in the vast majority of low-grade fibromyxoid sarcomas and negative in perineurioma and most other spindle cell tumors that are in the differential diagnosis. So MUC4 is really useful. Also, there are translocations, of course, for low-grade fibromyxoid sarcoma, and that's a FUS-CREB3L1 or FUS-CREB3L2. And you can do FISH or RT-PCR to detect those if you're worried about low-grade fibromyxoid sarcoma. The very last thing I'll briefly mention is that meningiomas can occasionally occur in the soft tissue outside of the central nervous system, either in the head and neck region of young kids, where they probably arise kind of as an ectopic focus of stem cells that then grow into a meningioma, or because they have grown, it's a meningioma from the CNS that's grown through the skull, through a defect in the skull, or a metastasis, which is very rare. But those things are possibilities that you can sometimes have meningiomas in soft tissue. And meningioma, of course, will stain with EMA, and it will swirl and whirl and have many of the features we saw here. Obviously, if you have psammoma bodies, that's one feature to make you think. If you're on the head and neck, or if the patient has a known history of meningioma, you should automatically think about meningioma there. But there are some stains that you can do to help. There was a nice study, and again, I'll put the link down below, that EMA is positive in basically all of the meningiomas and perineuriomas in the study, but when EMA, claudin, and GLUT were all positive together, that was seen in the majority of perineuriomas, but rarely, only in 1 or 2 cases, I think, of the meningiomas in soft tissue. So when you look at a meningioma, if you think it might be meningioma, but claudin and GLUT are both positive, that's a strong argument against it. Additionally, there are 2 stains, progesterone receptor, PR, and somatostatin receptor 2, SSTR2, and those stains will both be positive in the vast majority of meningiomas, but rarely ever positive in perineurioma. So you can use a panel of EMA with claudin, GLUT1, SSTR2, and PR if you're really having a hard time telling apart meningioma from perineurioma. So I know that was a lot of material, but I hope that that helps you have a better concept of what perineuriomas look like and how to work them up and approach them in practice. Please click like below and subscribe to my channel if you enjoyed this video, and please leave comments and feedback for me if you like these videos, what you like about them, and topics you'd like me to cover in the future. Thanks so much for watching. Have a great day.